From the American Neurological Association, I'm Adeline Goss. This is ANA Investigates. The emergence of the syndrome known as long COVID has brought new attention to a previously identified syndrome, Myalgic Encephalomyelitis chronic fatigue syndrome, or ME/CFS. The precise relationship between long COVID and ME/CFS is not yet understood, but our guests today argue that the science around ME/CFS is advancing in ways that may bring hope to patients suffering from the condition. Dr. Sonya Marshall-Gradisnik is director of the National Center for Neuroimmunology and Emerging Diseases at Griffith University in Queensland, Australia. Kiran Thapaliya is a postdoctoral research fellow at Griffith University. They spoke to ANA producer Dr. Richie about their research into ME/CFS and how neurologists should approach this condition. Here's Megan.
Sonya and Kiran, it's great to have you here on ANA Investigates to discuss the evolving entity of myalgic encephalomyelitis chronic fatigue syndrome, or ME/CFS.
Hi, I'm Sonya Marshall-Gradisnik, and thank you so much for having me on this podcast.
Hi, I'm Kiran Thapaliya. Glad to be here. Thank you.
So, tell me about some of the most common misperceptions in the medical community regarding myalgic encephalomyelitis, or chronic fatigue syndrome.
Well, I think it's not only a misconception in the medical community, but it's also in the wider community. So myalgic encephalomyelitis, it's also called chronic fatigue syndrome, but we'll call it ME from here on in. Previous research has indicated it's a psychological or a psychiatric component, which underlies the biological mechanism of the illness. Now, research here at the National Centre for Neuroimmunology and Emerging Diseases at Griffith University in Australia, as well as internationally, has clearly outlined there is a biological underpinning of ME. And more importantly, CBT, or cognitive behavioural therapy, or graded exercise therapy, are not underpinning a way forward for a treatment.
Thank you for explaining that. Now, how has the emergence and recognition of long COVID affected our understanding and our acceptance of ME?
Well, that's an interesting question. And I guess if we look at the symptoms of long COVID, there is definite overlap with ME. So if we look at symptoms such as headache, respiration changes, sleep disturbances, neuroimaging issues and changes, there's post-exertional malaise, there's pain, there's muscle, body pain, cardiac issues. There's a plethora of symptoms that long COVID patients report that significantly overlap and are reported with ME. So what does that actually mean? Well, first and foremost, the pain and the fatigue that's reported with long COVID has been recognised as an important factor that also ME patients also report. And therefore, there's a question whether or not long COVID is actually ME. That's where we're at the moment. So there is a degree of recognition as well as perhaps acceptance that unfortunately COVID has then caused patients with long COVID and they ultimately may have ME.
That's so interesting. Tell me about the term myalgic encephalomyelitis. It's one that sounds like it's been evolving a lot, and I'm curious about how you feel about the term and what you think it helps us understand about the disease.
Well, the term myalgic encephalomyelitis, myalgia means obviously pain, and encephalitis means obviously inflammation and potentially neuroinflammation. So a lot of patients who have ME report those key symptoms. Now, they're not only the exclusive symptoms, they also have, changes in cardiac function, respiratory function, and a number of sleep disturbances. They still have altered vision, smell, etc. So when you look at a definition of ME, that seems to be the purest way of looking and defining it at the moment with symptom presentation.
So, Kiran, I'm wondering, could you briefly review when a neurologist should consider ME in a patient? given how common many of the symptoms of ME are, what features do you think are the most helpful in its diagnosis?
ME is a complex illness that has no diagnostic or laboratory test. ME patients has heterogeneous symptoms that involves multiple organ systems, for example, gastrointestinal, cardiovascular, immune, and neurological systems. A neurologist may consider a ME as a potential diagnosis when there is evidence of unexplainable fatigue, specifically post-exenal fatigue that does not go away with rest, cognitive impairment, sleep disturbance and body pain, and neurosensory disturbance such as sensitivity to light. However, ME symptoms overlap with other diseases like thyroid, multiple sclerosis, or autoimmune. Therefore, for the proper diagnostic criteria of ME, these must be excluded.
So you mentioned inflammation as being an important part of the term myalgic encephalomyelitis. So I wondered, what do we understand about the pathophysiology of ME?
Well, it's an interesting question. And I guess if we go back to first principles, ME is actually recognized by the World Health Organization, and it's classified in the International Classification of Diseases, version 11, as a neurological disease. Now, when we look at the recent research in ME, what we find is there's numerous reports on ion channel changes, and ion channels are very important because they bring calcium into every cell of the body. Similarly, there's other research that has aligned to that theory with changes in MRI imaging in ME, along with changes in mitochondrial function. And we know that calcium is very important for mitochondrial function. So that body of literature and research clearly shows that the ICD classification is neurological, and we're evolving that hopefully in the coming versions.
So you've mentioned how cognitive behavioral therapy is not an appropriate treatment path forward for ME, and you have mentioned an inflammatory component. Tell us about the management of ME. Immune suppression, is it unknown? What pitfalls should neurologists be aware of in treating these patients?
Currently, there are no universal or specific FDA-approved drugs for ME treatment, although some medications are used off-label for the illness. However, some of the symptoms can be managed. Managing these symptoms might provide relief for some patients with ME, but not for others. For example, post-exenal malaise, which is the most common symptoms in ME, can be managed by activity management. Patients need to find their individual limits for mental and physical activity. They can break down the activity into small chunks with rest breaks in between, and they must listen to their body. And they can use memory aids like organizers, calendars that can help to manage their memory problems. And they can use, for example, earplugs, eye mask, sunglasses to minimize light and noise.
I can add to that too, what Kiran has just said. When you look, there is no universal treatment. So each patient obviously tailors their management in accordance with what I have identified as what makes them worse. And that usually means that they withdraw certain things. They withdraw from society. They don't have any like chemicals in the house. They don't have perfumes. They don't like to travel in the car. They don't like a lot of light. Those actual stimuli ensure that the patient actually feels worse. So they manage it on an individual basis by firstly identifying what are the triggers and then subsequently then removing them. So that's something a neurologist could be cognizant of, asking what are the triggers that make these people worse with their illness.
So could you tell me any examples of how misperceptions about ME have impacted patients that you've encountered?
There's numerous examples. Patients have reported that there is disbelief that they actually are unwell to the point that they cannot have any personal hygiene. They are cognitively impaired. They have major cardiac issues where they've got postural orthostatic tachycardia syndrome, or TAP-POTS, and they've been told that it is all in your head.
So tell us, how does advocacy inform a way forward for ME patients?
Well, that's an interesting question. And I think if you look at it in the first instance, a unified advocacy group worldwide is the first important step. And a way that that's been taken on is through the International ME Awareness Day, which is the 12th of May every year. And it's about showing the research that's rigorous, showing those representatives of the rigorous research that promotes this illness and legitimizes this illness as a biological illness that has a biological mechanism. And for that reason, that's why we've gone forward with funding. We always can have more funding for research because research informs and identifies diseases. And for that reason, advocacy is key because they unite researchers and then they inform also those people that are going to make changes.
So for early investigators interested in ME, what do you see as the most current and immediate needs to progress our understanding?
Yes, for an early investigator like me, I would say the foremost is like basic understanding about ME/CFS is very important. So this is also a multi-organ system illness with wide range of symptoms, as we mentioned earlier. And another important thing is the funding. I hope it will continue in the future, as Sonya mentioned that there is some link between the ME and long COVID. Now, people might put more funding on ME, and we need more funding, I would say, as an early career investigator to do more research on ME. And another, like as an early career investigator like me, we could focus more looking into the fundamental causes of ME/CFS and prioritize on the multifocal studies combining immunology, neurology, endocrinology, and genetics that possibly identify the causes, biomarker, and possible treatment of ME.
I'll add to that too. The unification of researchers worldwide, because we might do many studies in Australia here at NCNED, and then those studies need to be obviously replicated and validated in other sites around the world. So unification of researchers, unification of institutions, where we all work on a common goal. And I guess the most recent example of that would be with the COVID era. We all pooled our talent, we all pooled our expertise, and we came through within 18 months and developed vaccines. But that was a unified worldwide approach. And for this reason, it's just not down to individual talent, it's down to how we can come together as a collective.
Thank you so much, Kiran and Sonya, for being here to talk with us.
Thank you so much for having me.
Thank you so much, Megan, having me here too.
That was Dr. Sonya Marshall-Gradisnik, Director of the National Centre for Neuroimmunology and Emerging Diseases at Griffith University in Queensland, Australia, and Kiran Thapaliya, Postdoctoral Research Fellow at Griffith University. They were interviewed by Dr. Megan Richie of UCSF. ANA Investigates is the official podcast of the American Neurological Association. The show's producers are members of the ANA Education Innovation Committee, chaired by Megan Richie. I'm Adeline Goss, podcast host and executive producer. Our program was produced today by Megan Richie and me, with help from Jen Hurley. You can listen to past episodes of ANA Investigates and access all of the ANA's educational programs at myana.org. That's it for ANA Investigates. See you next month.